Hello, and welcome to Chapter 22, the Respiratory System. We require a continuous supply of oxygen so that our trillions of cells can carry out their vital functions. We can live without food or water for days, but we cannot go without oxygen for even a little while. As our cells use oxygen, they also give off carbon dioxide, which is a waste product the body must get rid of. The major function of the respiratory system is to supply the body with oxygen and dispose of carbon dioxide. To accomplish this function, at least 4 processes must collectively take place. This is called respiration. The respiratory system is responsible for only the first 2 processes, which are pulmonary ventilation and external respiration. The respiratory system is responsible for the first 2 processes, which I just mentioned, but it cannot accomplish its primary goal of obtaining oxygen and eliminating carbon dioxide unless the 3rd and 4th processes also occur. The 3rd process is the transport of respiratory gases, and the 4th process is internal respiration. As you can see, the respiratory and the circulatory systems, which is the cardiovascular system, are closely coupled. And if either system fails, the body's cells begin to die from oxygen deprivation. The actual use of oxygen and production of carbon dioxide by tissue cells is known as cellular respiration. It is the cornerstone of all energy-producing chemical reactions within the body. Because it moves air, the respiratory system is also involved with the sense of smell and with speech. The first process is pulmonary ventilation, and pulmonary ventilation is known as breathing. Ventilation consists of both inhalation and exhalation. Inhalation moves air into the lungs from the atmosphere. Exhalation moves air out of the lungs into the atmosphere. The second process, which is external respiration. External respiration, meaning that our source is external. It is outside the body. External respiration allows oxygen to diffuse from the lungs into the blood. So where did the lungs get the source of oxygen? The atmosphere. So that is external respiration, when oxygen is diffused from the lungs into our blood. That is external respiration. The 3rd process is the transport of respiratory gases. We know that one of the major functions of the cardiovascular system is to transport gases, both oxygen and carbon dioxide, within the blood. And the 4th process is internal respiration. Internal respiration, meaning that the source of the oxygen is within the body. Internal respiration allows oxygen to diffuse from the blood into the cells of our tissues. The respiratory system includes the nose, the paranasal sinuses, the pharynx, the larynx, the trachea, the bronchi, and their smaller branches in the lungs, which contain tiny air sacs called alveoli. The pharynx is known as the throat, the larynx is known as the voice box, and the trachea is known as the windpipe. The alveoli are the major sites of gas exchange. The anatomical structures of the respiratory system that I just mentioned can be divided or classified as the upper respiratory tract structures or the lower respiratory tract structures. The upper respiratory system consists of all the structures from the nose to the pharynx. The lower respiratory system includes all of the structures from the larynx to the alveoli. Please refer to this table as well as this table to study all the functions and features of those structures that make up both the upper respiratory system and the lower respiratory system. So here we have our nasal cavity, the nose, we have the pharynx, we have the oral cavity because some individuals are mouth breathers, we have the larynx, we have the trachea, we have the bronchi, and then we have the two lungs. Also have that dome-shaped muscle that you studied in anatomy and physiology too, which is the diaphragm. The diaphragm is the major muscle for breathing. It was also the muscle that you studied in AMP1 that separates the thoracic cavity from your abdominal pelvic cavity. Anatomically, the lower respiratory system consists of the larynx, the trachea, the bronchi, and the lungs. Functionally, the respiratory system as a whole consists of two zones, the respiratory zone and the conducting zone. The conducting zone consists of all the respiratory passageways from the nose to the respiratory bronchioles. These provide a fairly rigid conduit for air to reach the gas exchange sites. The respiratory zone, the actual site of gas exchange, is composed of the respiratory bronchioles, the alveolar ducts, and the alveoli. Again, please refer to this table for the function and features of those structures. The pharynx connects the nasal cavity and mouth superiorly to the larynx and esophagus inferiorly. The pharynx is known as your throat. It resembles a short length of garden hose as it extends for about 5 inches from the base of the skull to the level of the 6th cervical vertebrae. From superior to inferior, the pharynx is divided into 3 regions. The nasopharynx, the oropharynx, the laryngopharynx. The nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx, because it lies above the point where food enters the body, it serves only as an airway passageway. During swallowing, the soft palate and its pendulous uvula moves superiorly, an action that closes off the nasopharynx and prevents food from entering the nasal cavity. The nasopharynx is so named because the pharynx is attached posteriorly to the nasal cavity. Moving more inferior is the oropharynx. It lies posterior to the oral cavity and is continuous with it through an archway. The oropharynx extends inferiorly from the level of the soft palate to the epiglottis. Both swallowed food and inhaled air can pass through the oropharynx. The laryngopharynx, and even more inferiorly, serves as a passageway for both food and air and is lined with a stratified squamous epithelial tissue. The laryngopharynx is continuous with the esophagus posteriorly. The esophagus will be discussed in greater detail in our digestive system. It conducts food and fluids to the stomach. Air enters the larynx anteriorly and travels into the anterior trachea, where it will enter into the lungs. During swallowing, food has the right of way, and air passage will temporarily stop. This is controlled by the epiglottis. The larynx, known as the voice box, extends for about 2 inches from the level of the 3rd to 6th cervical vertebrae. Superiorly, it attaches to our hyoid bone and opens into the laryngopharynx. Inferiorly, it is continuous with the trachea. Here's the trachea. The larynx has 3 functions. It provides a patent open airway. Therefore, it's a part of the conducting zone. It is also a part of the lower respiratory tract. It acts as a switching mechanism to route air and food into the proper channels. It also serves as voice production because it houses the vocal cords. There are 9 cartilages that surround the trachea. They are all considered hyaline cartilage except for the epiglottis. The epiglottis, as you learned from AMP1, is made up of elastic cartilage. The large thyroid cartilage that you see here is formed by the 2 cartilage plates at the midline, forming a laryngeal prominence. This laryngeal prominence can be seen externally as the Adam's apple. The Adam's apple happens to be more prominent in males because of the hormones that stimulate growth during puberty. Inferior to the thyroid cartilage is cricoid cartilage. Mucosal folds called the vocal folds or true vocal cords, which appear pearly white because they lack blood vessels, vibrate, producing sounds as air rushes up from the lungs. The vocal folds and the medial opening between them through which air passes is called the glottis. Superior to the vocal folds is a similar pair of mucosal folds called the vestibular folds. These are our false vocal cords. These play no direct part in sound production, but will help to close the glottis when we swallow. This first diagram you see is when there's a closed glottis, so no production of sound. Here in the second photo, you can see the glottis is open, producing sound and allowing passageway of air into the trachea. You can see the ringed trachea that allows air to pass through because the glottis is open. That is your larynx and the vocal folds. Inflammation of the vocal cords is called laryngitis. This interferes with vibration, and because of that, we hear changes in our vocal tone, which causes hoarseness, or in severe cases, limiting us to a whisper. Laryngitis is most often caused by viral infections, but can also be due to overuse of the voice, very dry air, bacterial infections, tumors on the vocal cords, or inhalation of irritating chemicals. The air passageways in the lungs branch and branch again, about 23 times overall, a pattern often called the bronchial tree. At the tips of the bronchial tree, conducting zones give way to our respiratory zone structures. So let's reiterate what our conducting zone structures are. The nose, the pharynx, the larynx, the trachea, the major or primary bronchi, the secondary bronchi, the tertiary bronchi, the terminal bronchioles. All of those structures make up your conducting zone. The conducting zone is also known as the anatomical dead space. The anatomical dead space is just a volume of air that does not contribute to gas exchange. This conducting zone only acts as a passageway air. The trachea, which we see here, divides to form the right and the left main or primary bronchi. This takes place approximately at the level of T7 in an erect standing person. The structure where the trachea bifurcates or splits into the main bronchi is called the carina. Each bronchus runs obliquely in the mediastinum before plunging into the medial depression, or what we call the hilum, of each lung. The right bronchus is wider, shorter, and more vertical than the left. Consequently, because of that, it is more common for an inhaled foreign object to get stuck there. That's where our 2-year-olds get marbles and jacks stuck. Once inside the lungs, the main bronchus is going to divide into the secondary or lobar bronchi. The lobar bronchi will then branch into our tertiary or segmental bronchi. The tertiary bronchi will then branch into the bronchioles, that will then branch into the terminal bronchioles, completing our conducting zone. The respiratory zone structures will include the respiratory bronchioles down to the alveoli. It is defined by the presence of our thin-walled air sacs called alveoli, which are the major sites of gas exchange. The respiratory zone begins as the terminal bronchioles feed into our respiratory bronchioles, within the lung. The respiratory bronchioles will then lead into our winding alveolar ducts, and the alveolar ducts will then lead into our cluster or our major site of gas exchange, the alveoli. The alveolar ducts into the clusters of our alveolar sacs, which is this entire structure. You can see 4 alveolar sacs here. And each alveolar sac is made up of millions and millions individual alveoli, which is the main site of gas exchange. Many students mistakenly equate our alveoli, the individual structure, which I'll draw here. Give me 1 second. I am going to circle just one alveoli, okay? And now I am going to circle the entire alveolar sac, okay? So as I was mentioning, many students mistakenly equate the alveoli, the site of gas exchange, with our alveolar sac, but they are not the same thing. The alveolar sac, highlighted in purple, is analogous to a bunch of grapes, and the alveoli, highlighted in the red, the individual grape. There's 300 million or so gas-filled alveoli in our lungs that account for most of our lung volume and provide a tremendous surface area for gas exchange. Here's a representation of what it looks like from our alveolar duct, our individual alveolar sacs. We learned from AMP1 that inside our lungs and our alveolar sacs, we have simple squamous epithelial tissue. So this is our histological representation of simple squamous epithelial tissue. The external surfaces of our alveoli are densely covered with pulmonary capillaries. Gas exchange occurs readily by simple diffusion across this respiratory membrane. Oxygen passes from the alveoli into the blood. This is external respiration, and carbon dioxide will leave the blood and enter into the gas-filled alveoli to be exhaled from the body. There are several major types of cells found in the alveoli. We have type 1 alveolar cells. Type 1 alveolar cells function is gas exchange. Type 2 alveolar cells is to secrete a fluid called surfactant. Surfactant is responsible for reducing the surface tension within our alveoli, therefore preventing collapse of our lungs. The paired lungs occupy all of our thoracic cavity except the mediastinum region. In the mediastinum region is housing the heart. Great blood vessels, our bronchi, our esophagus, and other organs. Each cone-shaped lung is surrounded by pleurae and connected to the mediastinum by vascular and bronchial attachments collectively called the lung group. This is our right lung, and this is the left lung. The pleural serosum membranes are going to be found in the pleural cavity. The pleural cavity, the name itself suggests that the cavity houses the lungs. We have a right pleural cavity and a left pleural cavity because the lungs are separated by the heart. The pleurae form a thin double-layered serosa. The layer called the parietal pleura covers the thoracic wall and superior face of the diaphragm. The viscera pleura is the layer that covers the external lung surface, dipping into and lining its fissures. The two layers are separated by a pleural cavity that houses pleural fluid. This lubricating secretion allows the lungs to glide easily over the thorax wall during our breathing movements. The pleura also help divide the thoracic cavity into three chambers: the central mediastinum for the heart and the two lateral pleural compartments for each lung. Inflammation of the pleura often results from pneumonia and causes pleurisy. This is going to be characterized by rough friction and stabbing pain with each breath. The pleura may produce excessive amounts of fluid. This increased fluid relieves the pain caused by pleural surfaces rubbing together, but it also may exert pressure on the lungs and hinder breathing. The term for fluid accumulation in the pleural cavity is pleural effusion. On the mediastinal surface of each lung is this indentation. This indentation is called the hilum. The hilum is the structure which pulmonary and systemic blood vessels, the two main or primary bronchi, the lymphatic vessels, and nerves will enter and leave the lungs. The two lungs differ slightly in its shape and size because the apex of the heart is slightly to the left of the median plane. The left lung is smaller than the right due to the cardiac notch that accommodates the heart. The left lung is subdivided into superior and inferior lobes. The lobes are separated by the oblique fissure. The right lung has three lobes: the superior lobe, the middle lobe, and the inferior lobe, and therefore it has two fissures: the horizontal fissure and the longitudinal or oblique fissure. Oblique fissure. Before we discuss the breathing process, it is important to understand that respiratory pressures are always described relative to atmospheric pressure. Atmospheric pressure is the pressure exerted by the air surrounding the body. At sea level, atmospheric pressure is 760 millimeters of mercury. A negative respiratory pressure in any respiratory area indicates that the pressure in that given region is lower than our atmospheric pressure. A positive respiratory pressure is higher than atmospheric pressure. A zero respiratory pressure is equal to atmospheric pressure. In addition to atmospheric pressure, It is notable to also note intrapulmonary pressure, also known as intra-alveolar pressure. This is the pressure found in the alveoli of the lungs. The intrapulmonary pressure rises and falls with the phases of breathing. So it rises and falls during inhalation or exhalation. The second pressure to know, in addition to atmospheric pressure, is the intrapleural pressure. This is the pressure found in the pleural cavity. It should always be negative, relative to our intra-alveoli, or also called intrapulmonary pressure. Any condition that equalizes our intrapleural pressure with the intrapulmonary or atmospheric pressure causes immediate lung collapse. You can see the collapsed lung here. That's a collapsed lung. The pink region is smaller than what we see in the other diagrams, okay? Collapsed lung is called atelectasis, and this occurs when a bronchiole becomes plugged, as in pneumonia, or rupturing either the parietal or the visceral pleural can also cause a collapsed lung. The presence of air in the pleural cavity is referred to as a pneumothorax. Pneumo means air. Where is air located? In the thorax. It is reversed by drawing air out of the intrapleural space with chest tubes. So any rupture to the pleural cavity of the space where the lungs reside will cause your lungs to collapse, cause a pneumothorax. So here's a punctured parietal pleural with a knife wound. Here's a ruptured visceral pleural, often spontaneously, maybe due to a car accident, any trauma to the thoracic cavity. And here is a neurothorax, where air enters into the pleural pressure. As a result, the lungs are going to collapse. Okay. So let's recap our pressures. As the thoracic dimensions increase during inhalation, the lungs are stretched and the intrapulmonary volume increases. If the intrapulmonary volume increases, pressure decreases. Anytime the intrapulmonary pressure is less than the atmospheric pressure, air rushes in to the lungs along the pressure gradient. During the same period, the intrapleural pressure also declines. During deep or forced inspiration, or vigorous exercise, or in a chronic obstructive pulmonary disease, we have accessory muscles such as our internal intercostal muscles, our scalenes, and our sternocleidomastoid muscles of the neck and the pectoralis minor will allow the chest to raise the ribs even more than what happens during quiet or normal inhalation. In healthy individuals, quiet exhalation is a passive process that depends more on lung elasticity than on muscle contraction. The inspiratory muscles relax and resume their resting length. The rib cage descends and the lungs recoil. As a result, both the thoracic and the intrapulmonary volumes decrease. If the volume decreases, pressure increases above the atmospheric pressure, and gases flow out of the lungs. So this slide is going to summarize the events that happen during inhalation and exhalation. So during inhalation, the first thing that must happen is our inspiratory muscles, which include the diaphragm and your external, are going to contract. When they contract, the diaphragm is going to change shape from its dome shape to a flat shape. The rib cage is going to rise. Ribs are elevated as a result of the contraction of the external intercostal muscles. It elevates the sternum and allows the thoracic cage to expand. When that happens, we can say that the volume within the thoracic cavity or within the space has increased. When the volume increases, pressure decreases. The lungs are stretched, the intrapulmonary volume increases, and as a result of that, the pressure decreases. When the pressure decreases, it is now lower than the atmospheric pressure, and air, which will be containing oxygen, will flow into the lungs down its pressure gradient, and that is inhalation. Exhalation, the opposite is going to occur. So because it's a passive process, and if a muscle contracts, it's going to automatically relax. The diaphragm and the external intercostal muscles contracted during inhalation, so now they're going to automatically relax. When they relax, the diaphragm rises back to its original dome shape. The external intercostal muscles are going to relax, causing the ribs and the sternum to depress or move inferior, causing the thoracic cage to recoil. Therefore, the space, the thoracic cavity volume decreases. And when volume decreases, the pressure is going to increase. So the pressure inside the lungs, the intrapulmonary pressure, or also called the intraalveolar pressure, is going to increase. It is now higher than the atmospheric pressure. And because it's higher than the atmospheric pressure, it wants to push the air out of the lungs into the environment. Those are the events of exhalation. I would like to now take this time and introduce you to Boyle's law. Boyle's law gives the relationship between pressure and volume, which we just went over in the sequence of events for inhalation and exhalation. Boyle's law states that at a constant temperature, the pressure of a gas varies inversely with its volume. That means that as pressure increases, volume decreases, or as pressure increases, volume decreases, and vice versa. At this time, I will also like to introduce to you Dalton's law and Henry's law. These two laws are the basic property of gases. Beyond Boyle's law, two more gas laws provide most of the information that we need. Dalton's law of partial pressure states or reveals how a gas behaves when it's part of a mixture of gases. And Henry's law will help us understand how those gases move in and out of the blood. Dalton's law of partial pressure states that the total pressure exerted by a mixture of gases is the sum of the pressures exerted independently by each gas in the mixture. Henry's law states that when a gas is in contact with a liquid, the liquid here being the blood, the gas will dissolve in the liquid in proportion to its partial pressure. So the greater the concentration of a gas, the more and the faster that gas will go into the solution or dissolve in the solution. This is the solubility of a gas. How much of a gas will dissolve in a liquid at any given partial pressure depends on its solubility. The gases in air have very different solubilities in water or in blood. Carbon dioxide is the most soluble. It can dissolve more readily than any other gas within the blood. For this reason, at a given partial pressure, much more carbon dioxide than oxygen dissolves in the blood. And therefore, oxygen has to be transported, bound to the hemoglobin, hemes, in our red blood cells. Okay. So just to recap, pulmonary ventilation, which is breathing, consists of two phases, two processes, inhalation and exhalation. Pulmonary ventilation, known as breathing, is a mechanical process that depends on volume changes in the thoracic cavity. A rule to keep in mind is that volume changes lead to pressure changes, and pressure changes lead to the flow of gases to equalize the pressure. There are various factors that hinder air passage and pulmonary ventilation. They are airway resistance, alveolar surface tension, and lung compliance. The amount of air flushed in and flushed out of the lungs depends on the conditions of inhalation and exhalation. Respiratory capacities and respiratory volumes are measured to gain information about a person's respiratory status. Lung volumes and capacities are often abnormal in people with pulmonary disorders. Pulmonary means lung. A pulmonologist is a doctor specialist that is going to study the lungs. The original clinical measuring tool is a spirometer. This is an instrument that is most useful for evaluating losses in respiratory function and for following the course of certain respiratory diseases. Spirometry cannot provide a specific diagnosis, but it can distinguish between obstructive pulmonary diseases involving increased airway resistance, such as chronic bronchitis, between restrictive diseases involving reduced total lung capacity, such as tuberculosis or fibrosis. We can obtain more information by assessing the rate at which gas moves into and out of the lungs. A test known as the forced vital capacity measures the amount of gas expelled when an individual takes a deep breath and then forcefully exhales maximally and as fast as possible. The forced expiratory volume determines the amount of air exhaled during specific time intervals of the forced vital capacity test. Those with healthy lungs can exhale about 80% of the forced vital capacity within 1 second. The four respiratory volumes of interest are tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. During normal, quiet breathing, about 500 milliliters of air moves into and out of the lungs with each breath. Normal quiet breathing is what we're doing at rest. Now, if we were to get up and do 25 jumping jacks or run on the treadmill or chase our dog around the house, our tidal volume would increase, and that's no longer normal, quiet breathing. It's deep breathing, forceful breathing. This respiratory volume is known as tidal volume. Tidal volume is the amount of air inhaled or exhaled with each breath under resting conditions. And this is typically in normal, healthy individuals about 500 milliliters. You don't have to know the difference between the genders. The amount of air that can be forcefully inhaled beyond the tidal volume is known as our inspiratory reserve volume. The expiratory reserve volume is the amount of air that can be forcefully exhaled from the lungs after a normal tidal volume exhalation. Even after the most strenuous exhalation, air can still remain in the lungs. This is known as residual volume. Residual volume helps to keep the alveoli open and prevent lung collapse. Our respiratory capacities include inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. The respiratory capacities always consist of 2 or more lung volumes. Please know these equations. Inspiratory capacity is the total amount of air that can be inhaled after a normal tidal volume. So it is the sum of tidal volume plus inspiratory reserve volume. Our functional residual capacity represents the amount of air remaining in the lungs after a normal tidal volume exhalation, and it is the combined residual volume plus expiratory reserve volume. Vital capacity is the total amount of air that can be exhaled and inhaled. It is the total amount of exchangeable air. It is the sum of tidal volume, inspiratory reserve volume, and expiratory reserve volume. And our last capacity is total lung capacity. Total lung capacity is going to be the sum of all the lung volumes. That's tidal volume plus inspiratory reserve volume, expiratory reserve volume, and residual volume. Total lung capacity is the amount of air that the lungs can hold at any given time. That totals 6,000 milliliters. 6,000 milliliters equates to 6 liters. Molecular oxygen is carried in the blood in 2 ways: bound to hemoglobin within our red blood cells or dissolved in plasma. However, based on Henry's law, we just learned that carbon dioxide is the most soluble gas in blood. Oxygen is poorly soluble in blood. Hemoglobin, of course, can solve that problem. 98.5% of the oxygen that is carried from the lungs to our tissues is bound to hemoglobin. Hemoglobin is composed of 4 polypeptide chains. We learned this during our blood chapter, each bound to an iron-containing heme group. And because the iron atoms bind oxygen, each hemoglobin molecule can combine with 4 molecules of oxygen. And oxygen loading is rapid and reversible. When all four of the heme groups are bound to 4 molecules of oxygen, the hemoglobin is said to be fully saturated or fully loaded. The rate at which hemoglobin reversibly binds or releases oxygen is regulated by the partial pressure of oxygen, so how much oxygen is present, the temperature, our blood pH, the partial pressure of carbon dioxide, how many molecules of carbon dioxide is present, and also the blood concentration of an organic chemical called 2,3-bisphosphoglycerate. These factors interact to ensure that adequate oxygen is delivered to our tissue cells. So this slide represents the oxygen hemoglobin dissociation curve. Okay? The oxygen hemoglobin dissociation curve. This curve shows how local partial pressure of oxygen molecules controls oxygen loading and unloading from hemoglobin. So the purple line in the center of this graph represents normal. The hot pink line represents unloading of oxygen in hemoglobin. The blue line I can't get it. Okay, represents loading of oxygen in hemoglobin. Okay. Hemoglobin ensures adequate oxygen delivery under a variety of conditions. And this is oxygen delivery to our tissues. Under normal resting conditions, hemoglobin is said to be 98% or 100% saturated with oxygen. Temperature, blood pH, partial pressure of carbon dioxide, and the amount of BPG in the blood all influence hemoglobin saturation at a given partial pressure of oxygen. Red blood cells produce BPG, or also known as 2,3-bisphosphoglycerate, as they encounter glucose. BPG binds reversibly with hemoglobin, and its levels increase when oxygen levels are low. All of these factors influence hemoglobin saturation by modifying hemoglobin's structure, thereby changing its affinity, its attraction for oxygen. An increase in temperature, partial pressure of CO2, hydrogen ions, therefore decreasing our pH or causing acidosis, and an increase in BPG levels in the blood will all lower hemoglobin's affinity for oxygen. An increase in any of these factors will lower oxygen's affinity for hemoglobin and therefore cause unloading. Unloading is actually what the goal is. If we unload oxygen from hemoglobin, from our red blood cells, the oxygen is going to enter into our tissues and provide our cells with oxygen to carry out their functions. Okay? But conversely, let me change my colors. A decrease in any of these factors increases hemoglobin affinity for oxygen, decreasing oxygen unloading, therefore leading to loading. This change shifts the dissociation curve to the left. So a decrease in temperature, partial pressure of carbon dioxide, a decrease in hydrogen ions, and if we have a decrease in hydrogen ions, it means that our pH is rising, meaning that it's more alkaline, and a decrease in BPG. We know that we have a decrease in BPG because we have an increase in oxygen. So it is going to promote loading of oxygen to our hemoglobin molecule. Okay, and as you can see, the blue line shifts the curve to the left. So a curve shift to the left means loading. They both start with the letter L, loading left. A dissociation curve shift to the right is going to signify unloading. Okay. Both declining blood pH, which is acidosis, increase in our CO2 molecules leads to unloading of hemoglobin with oxygen, a phenomenon called the Bohr effect. This is called the Bohr effect. The Bohr effect. This enhances oxygen unloading where it is most needed. Oh, I spelled Bohr effect wrong. I'm sorry. It's B-O-H-R, the Bohr effect. Okay? Most carbon dioxide molecules enter the plasma quickly and then enter into our red blood cells. The reactions that convert carbon dioxide to bicarbonate ions for transport mostly occur inside of our red blood cells. So the reaction that converts carbon dioxide to bicarbonate usually occurs inside of our red blood cell. When dissolved carbon dioxide combines with water, so when CO2 binds with water, forming carbonic acid, it dissociates quickly into hydrogen ions and bicarbonate ions. This is known as the carbonic acid bicarbonate buffer system equation. This is how we maintain the pH of blood. A normal pH of blood is 7.35 to 7.45, and this equation allows us to control that. This reaction also occurs in the plasma, but it occurs even faster inside our red blood cells because they contain an enzyme called carbonic anhydrase. This enzyme reversibly catalyzes the conversion of carbon dioxide and water to carbonic acid. Hydrogen ions are then released, binding to hemoglobin, triggering that Bohr effect that we mentioned on the previous slide. Carbon dioxide loading enhances oxygen release, and because of this buffering effect of hemoglobin, the hydrogen ions causes little change in our pH under normal resting conditions, and that's our goal. The opposite effect is the Haldane effect. I'm going to change my color too. The Haldane effect. This is when the amount of carbon dioxide transported in the blood is affected by the degree to which blood is oxygenated. The lower the number of molecules of oxygen, and the lower the hemoglobin saturation with oxygen, the more carbon dioxide the blood can carry. This phenomenon is known as the Haldane effect. It reflects the greater ability of reduced hemoglobin to form carboaminohemoglobin and to buffer hydrogen ions by combining with it. So Haldane effect encourages or leads to unloading of oxygen to hemoglobin. And this completes the respiratory system. Thank you. I hope you enjoyed the respiratory system, anatomy, and physiology. Please remember to refer to your lecture PowerPoint for more detailed information. Thank you.